Welcome to today's webinar, Practical Insights of Cholesterol Guidelines for Secondary Prevention of ASCVD. This webinar is made possible by Novartis, a proud supporter of the American Heart Association's integrated ASCVD management initiative. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Today's presentation can be downloaded from the handout section in your control panel. If at any time during the webinar you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please contact the GoToWebinar customer service team found in your confirmation or reminder emails. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel or by sending by email to ascvdquestions@heart.org. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. I would like to now introduce our speaker for today, Dr. Salim Virani. Dr. Virani is a tenured professor in the sections of cardiology and cardiovascular research at Baylor College of Medicine in Houston, Texas. He serves as the director for the Cardiovascular Disease Fellowship Training Program at Baylor College of Medicine, and has served as the co-director for the Veteran Affairs Advanced Fellowship Program in Health Services Research and Development at Michael E. Dickey VA Medical Center. Dr. Virani's research portfolio aims to understand the pathophysiology and epidemiology of atherosclerosis, especially in South Asians, and how big data and point-of-care informatics-driven interventions can improve guideline-concordant care delivery. He has co-authored over 600 publications on various aspects of cardiovascular disease prevention. He has served as a panel member for the 2018 AHA-ACC Multi-Society Guideline on Cholesterol Management and the 2019 ACC-AHA Guideline for the Prevention of Cardiovascular Disease. Dr. Virani, thank you so much for joining us today. We will turn it over to you.
Thank you so much for the introduction. It's really my pleasure to talk about this topic that's very near and dear to me. Clinically, this is what I do for a living, and this is an area of active research for me as well. So really what I was asked to talk about is just talk about some practical insights that we can have in the management of patients with ASCVD, especially as it pertains to the cholesterol guidelines. These are my sources of research support as well as other disclosures, none of which are directly relevant to what we're going to be talking about. Now, at the outset, I wanted to recognize that guideline is really a team effort. What we're going to talk about today is the 2018 AHA-ACC Multi-Society Cholesterol Guideline. And the reason I use the word multi-society, as you can see on this slide, there are representatives from several other organizations. So this is not just AHA and ACC, but several organizations that were part of it. At the same time, you'll see a lot of leaders in cholesterol management who are actually the authors of this particular guideline. I mean, and just to tell you, our chair and vice chair, Dr. Grundy and Dr. Stone, they've been in this field for decades, and they've been part of almost every cholesterol guideline that has come out. Initially, those of you who know the history, the guidelines used to be developed at the NIH in late 70s, and then in the last 10 years or so, they have moved back to ACC-AHA, at least as far as the cholesterol guidelines are concerned. So there's a lot of experience in terms of the guideline writers, and this is really what I'm going to use today in terms of discussing some practical aspects related to cholesterol management in patients in secondary prevention, those who already have established ASCVD. So again, there are a few objectives I have. My first and foremost objective is to discuss with you and help you understand guideline recommendations for lipid management in secondary prevention of ASCVD. Remember, there are two big buckets when it comes to cholesterol guidelines. One is primary prevention, where we're trying to manage cholesterol to reduce somebody's risk of having their first vascular event. The ones we are talking about today are patients in secondary prevention of ASCVD, and I'll give you the specific definition of that in a minute. Again, the 2018 guidelines came up with I would say, a rather newer concept talking about very high risk ASCVD, but it's a concept that's very intuitive. So we'll talk about what is the definition of that very high risk ASCVD patient and why is that important. We'll talk about the concept of threshold LDL cholesterol levels to think about using non-statin lipid lowering therapy. Of course, statins are first line. I'll talk about that as well. Then we'll talk about some system level gaps in lipid management that we all need to be aware of. I'm sure almost all of you who are attending today are somehow related to either a practice or a healthcare system. And that's why it is important to understand and keep some numbers in mind that will be important for you as you're looking at cholesterol management from a systems perspective. And then there have been a lot of medications that have come out, and a couple of them have been approved by FDA recently to be used in secondary ASCVD prevention. And in fact, one of them is going to be a late-breaking clinical trial at the upcoming ACC meeting in March of 2023. So I thought that I'll spend the last 5 minutes or so to talk about those two other FDA-approved medications that have come out since the guidelines were published, because you will probably hear about them, or you are already hearing about those medications. So it would be good to know a little bit about those two medications as well. So with that, let's get started. And as I said, that this webinar pertains to secondary ASCVD prevention. So first, it would be extremely important to understand who are these patients. Now, this may be very simplistic for you, but there's a reason why I have this slide, and I'll get into that in a second. So again, when we talk about patients with clinical ASCVD, some of us use the term secondary prevention. These are patients with established atherosclerotic cardiovascular disease. So these would be patients with history of acute coronary syndrome. So somebody had myocardial infarction, whether that was ST elevation myocardial infarction, non-ST segment elevation myocardial infarction, unstable angina, stable angina, somebody who had any form of coronary or other revascularization performed. So if they had PCI, if they had bypass surgery, stroke or transient ischemic attacks, as well as patients with peripheral artery disease, including those with aneurysms that are deemed to be of atherosclerotic origin. Now I'll take a 5-second pause here to identify that when we look at patients who have clinical ASCVD, it's not only patients who had heart attacks or those who had stents or bypass surgery. Patients with history of ischemic strokes, as well as those with peripheral arterial disease, those who have disease in the superficial femoral artery or any of the other peripheral arteries, those that have had a stent there, are also secondary prevention patients. And I mentioned this because if we look at any large registry data, patients who have ischemic heart disease are treated much more aggressively compared to those who have history of ischemic stroke or PAD, although in terms of future vascular events, they all carry similar risk. And in some studies, patients with history of stroke or those with PAD may even carry higher risk of future cardiovascular events compared to patients with stable ischemic heart disease. So again, when we are looking at these patients in our practice, or we are looking at it from a healthcare system perspective, if you're one of those who's working in a large healthcare system and looking at data, please keep in mind that when we're talking about patients with clinical ASCVD, it's not only patients with heart disease, but also patients with ischemic stroke and PAD. So now when we know that that's our clinical patient population, let's talk about the guidelines. And I'm going to keep coming back to this slide over and over again. And I am going to be very repetitious, but that's by design. And the reason for that is that really, if you understand this one figure in the cholesterol guidelines that pertains to secondary ASCVD prevention, you pretty much can manage 80 to 90% of the clinical situations you have in terms of lipid management in secondary prevention. So I'm going to just keep coming back to this slide over and over again, come back, talk about a few things, show you some data, then bring you back to this figure, because I believe this will help you in delivering care that is very much guideline concordant. So when we talk about clinical ASCVD, please remember that we may talk about medications today, but we know that heart healthy lifestyle, whether it's primary or secondary prevention, is the foundational basis for any kind of prevention management, right? So when we talk about diet, we talk about physical activity, we talk about stress management, we talk about medication adherence in general, not just to lipid lowering medications, but all the medications. Those things remain extremely important. Once that is done, the 2018 guidelines took an approach of saying that not all secondary prevention patients are created equal. Those of you who are clinicians would understand. If I have a patient, for example, if I have a 58-year-old woman who had a stent done 6 years ago, doesn't have diabetes, does not smoke, she is not the same risk as a 70-year-old person who had an MI a week ago, continues to smoke, and has cholesterol of 150, 160, right? LDL cholesterol. So again, we have two patients who will be listed as secondary ASCVD prevention patients, but their risks are very different. So that is why the 2018 guidelines have taken an approach whereby we divide up secondary ASCVD patients into those not very high risk and those who are very high risk ASCVD patients. And the reason for that is that the guidelines are trying to be pragmatic. They're telling you that if we have very high risk ASCVD patients, those are the patients who have the highest risk of having a recurrent event, and consequently, we should maximize not just our statin therapy, but our non-statin therapy in those very high risk ASCVD patients. So let's start out with not very high risk patients, and as you can imagine, high intensity statin therapy remains a class 1 recommendation in those patients, whether they are high risk or not, right? So high intensity statin therapy is class 1, something that should be done, right? Those are things that are performance measures. So high intensity statin therapy is to be used in every clinical ASCVD patient, whether they are high risk or not very high risk. And we know that from various clinical trials, again, these are data from the Cholesterol Treatment Collaborative, what we call the CTT meta-analysis, where we know that every millimole reduction in LDL cholesterol is associated with almost a 21% relative reduction in the risk for future major vascular events. And that's what you see here, right? That's not the only thing. What we know in secondary prevention is that more is better. When we compare low to moderate intensity statin therapy versus high intensity statin therapy, and those are 5 trials where more statin is compared with less statin, we know that intensity of statin therapy also matters, whereby events are much lower with higher intensity statin therapy compared to low or moderate intensity statin therapy, and that's shown here in the CTT meta-analysis as well. The other aspect of that is that as much as we have controversy regarding use of statin therapy in primary prevention in older adults, in terms of secondary prevention, there is no heterogeneity of effect. So it does not depend whether you're dealing with a male or a female. It does not depend on the age of the patient. They all derive benefit from aggressive LDL cholesterol lowering in secondary prevention. So again, when you have patients with not very high risk of ASCVD, use of high intensity statin therapy remains a class 1 recommendation in those patients. You can divide them up into those aged less than 75 years. If they are less than 75, as I said, high intensity statin therapy is a class 1 recommendation, something that should be done. But then, of course, there are patients who may not be able to tolerate high intensity statin therapy, or there might be worries about medication interaction. So in those cases, using a moderate intensity statin again remains a class 1 recommendation. If you're dealing with an older adult in secondary prevention, what you will notice, which is a little bit of a departure from 2013 ACCHA guideline, is you can use either moderate or high intensity statin therapy. And if somebody was on high intensity statin therapy and they just celebrated their 75th birthday, it does not mean that we bring down the intensity of statin therapy if they're tolerating the therapy well. On the other hand, if they have medications that they're using that one is worried about in terms of interactions, if they have other competing illnesses, if you're worried about polypharmacy, in those cases, you can think about de-escalation of therapy, but age itself should not be the reason that we are talking about either a lower intensity of therapy or de-escalation of therapy. So just remember that if patients are tolerating high intensity statin therapy well, if they have now crossed that age of 75, there's no reason to down titrate or stop statin therapy in secondary prevention just because now they have celebrated their 75th birthday. So that's how we have the not very high risk group. Now, of course, we have this very high risk ASCVD group. So you may ask, why do we have a very high risk ASCVD group, and how do we treat those patients with statin therapy and non-statin therapy? So do remember that when we have very high risk ASCVD group, just like the not very high risk group, high intensity statin therapy and adherence to high intensity statin therapy remain class 1 recommendations, something we should emphasize before we move on to other therapies. And I'll show you the data that it's not just the intensity, it's also the adherence. We have to make sure that our patients are actually taking their high intensity statin. In clinical practice, we see this as a major problem, that it's not just prescribing high intensity statin therapy. A lot of those patients may not be taking the therapy either. Once high intensity statin therapy is used, then there are non-statin therapies that are recommended to be used specifically in this very high risk group, because these are the patients who will derive the most benefit from non-statin therapies. And the two non-statin therapies that currently have outcomes data are ezetimibe and PCSK9 inhibitors. We'll talk about both of them. And those are the ones that are recommended to be used in a sequential manner, ezetimibe first, followed by the use of a PCSK9 inhibitor. And we'll talk about that in terms of the threshold LDL cholesterol levels when those medications should be used. So now the first question you might ask is, why do we have a very high risk ASCVD category? And again, I can show you data from both trials of ezetimibe therapy as well as trials of PCSK9 therapy to convince you that there is a reason that we have this very high risk ASCVD category. So these are data from Improve It trial. And just to refresh your memory, Improve It trial was a trial done in patients with acute coronary syndrome where everybody received statin. And then patients were randomized to either receive ezetimibe or no ezetimibe. So everybody, even in your placebo arm, everybody received statin therapy. Now, when you take these patients, and these patients were followed for a median of about 7 years, and the average event rate was about 32-33% in this particular trial. Now, when you look at patients who had one of these 9 what I call risk indicators, and they are not uncommon: age, hypertension, heart failure, diabetes, prior stroke, prior bypass surgery, PAD, low EGFR, i.e. chronic kidney disease, or continued smoking. It makes sense, right? If you have these, your risk of having an event in the future will be higher. So if you just look at those patients who are on statin only, if you look at those patients, if they had 0 to 1 of these risk markers, their event rates were low. That's not a surprise. Remember, everybody in this trial had acute coronary syndrome to get in. But if you didn't have some of these other risk factors along with ACS, your risk of having an event in the future was low. As the number of these risk factors went up, so did your event rate. You see 13.1% to almost 40% if you had 3 or more of these high risk features. In fact, if you had 5 or more of these, which is not unusual, those of us who are taking care of patients would know, if you had 5 or more of these, then almost 70% of those patients actually had a recurrent cardiovascular event at about 7 years of follow-up. The other aspect of this, as the number of these risk markers go up, what you will notice is that the event rates go up, but that's not the full story. Patients derive more benefit by using ezetimibe as the number of these risk markers goes up. So one can use these risk markers, which are very easy things. We can all get these in our EHRs, right? You can differentiate between patients who are going to have high risk of future cardiovascular events, and consequently, these are the patients who will derive the most benefit by non-statin add-on therapies on top of statin therapy. Now, the same trial if you take patients who had polyvascular disease, so everybody got in because they had acute coronary syndrome. But if patients had concomitant history of ischemic stroke, or if they had peripheral artery disease, look at the event rate, 33% versus close to 50%. But at the same time, if you had polyvascular disease, the absolute risk reduction that one derived from ezetimibe therapy was much higher, and therefore the numbers needed to treat were extremely lower. If you had polyvascular disease plus diabetes, look at the event rates. Almost 65% of those patients had a recurrent event. But similarly, they derived a lot more benefit by the use of ezetimibe therapy. And again, saying that when patients have these other risk factors or risk markers, they have high risk of having a recurrent event, and therefore they derive a much larger absolute risk reduction by giving therapies on top of statin therapy. So you can identify patients who are going to derive more benefit by using a non-statin therapy. If you look at PCSK9 inhibitor trials, I just showed you data related to the use of ezetimibe. If you look at PCSK9 inhibitor trials, the outcomes trial we've had two up till now, Fourier trial, which was done in patients with stable ASCVD, and then Odyssey outcomes trial, which was done in patients with acute coronary syndrome. If you look at Fourier trial, it used major and minor criteria to enrich patients who have high risk of ASCVD in the future. Similarly, when you look at major subgroups of patients in these trials, there are patients who seem to derive a lot more benefit by the use of PCSK9 inhibitors. And those patients are patients who had recent MI, those who had more than one MI, those who have multi-vessel CAD, those with peripheral artery disease, and those with LDL cholesterols at baseline of 100 milligrams per deciliter or higher. So I'll show you again some of those subgroup analyses that will drill down the point that not all secondary prevention patients are created equal. So these are data from Fourier trial. And again, just to refresh your memory, Fourier trial was a trial where everybody was on statin therapy. These were stable ASCVD patients, so they did not have an acute cardiovascular event. These were stable ASCVD patients, prior history of MI, prior history of bypass surgery, prior PAD, prior ischemic stroke. Everybody received statin, and then patients were given PCSK9 inhibitor or placebo. And what you see here is that if you look at patients who were enrolled in this trial, and if their qualifying MI was more than 2 years versus less than 2 years, you will notice that if they had more recent MI in the placebo group, which is statin only, there was much higher event rate. If you had 2 or more MIs, the event rates were much higher compared to those who had 1 MI. And if you had residual multi-vessel coronary artery disease, your event rates were much higher, as one would expect, because these are high-risk patients. But at the same time, if you look at the risk reduction these patients derived by the use of a PCSK9 inhibitor, it was again much higher if you had a more recent MI, if you had 2 or more MIs, or if you had residual multivascular CAD, almost 3 times higher benefit compared to patients who were enrolled in these trials who received these medications but did not have these high-risk features. So that's what we saw in Fourier trial, which was stable ASCVD patients. If we look at patients in Odyssey outcomes, where another PCSK9 inhibitor was given to patients with acute coronary syndrome, we saw something very similar. If patients' baseline LDL cholesterol levels were high on statin therapy, again, everybody was on statin therapy in this trial, and then patients were randomized to a PCSK9 inhibitor or not, and in this case, they received alirocumab. What you will see is that if you look at patients who received placebo, that is statin only, but did not receive PCSK9 inhibitor, look at their event rates compared to those who had lower levels of LDL cholesterol. Much higher event rates, but at the same time, the absolute risk reduction by the use of a PCSK9 inhibitor was much higher in these patients compared to an average trial participant, 1.6% versus 3.4% if your baseline LDL cholesterol levels on statin therapy were higher. So what this tells us is that we can identify these patients who are very high risk of having recurrent cardiovascular event, and these are the patients who will derive the most benefit from the use of non-statin lipid-lowering therapies on top of statin therapy. So now when you come back to the guidelines have a definition for you as to what is the definition of a very high-risk ASCVD events. And it's pretty easy. What it is that if you had more than one major ASCVD events, which includes recent ACS or a history of MI in the past outside of the ACS event, history of ischemic stroke, or symptomatic peripheral arterial disease. So if you have 2 or more of these, you are a very high-risk ASCVD patient. On the other hand, if somebody has one of these major ASCVD events, but has 2 or more of these high-risk conditions, which includes age, heterozygous FH, prior bypass surgery or PCI, diabetes, hypertension, CKD, current smoking, persistently elevated LDL cholesterol, or history of congestive heart failure. So if you have one major ASCVD event and 2 or more of these high-risk conditions, you are again considered very high-risk ASCVD patient. And I'll show you what proportion of secondary prevention patients will fall into this very high-risk category in a few minutes. But this is how we define very high-risk ASCVD group as per the 2018 ACC/AHA cholesterol guidelines. So remember, 2 or more major ASCVD events or one major ASCVD event with 2 or more of these high-risk conditions will classify a patient as very high-risk secondary prevention or very high-risk ASCVD patient. So what do we do with these patients? Well, we continue with high-intensity statin therapy as a class 1 recommendation. That's for everybody. If they don't tolerate high intensity, then maximally tolerated statin therapy is a class 1 recommendation, something we should continue. But once we have done that, since these are the patients who have the highest risk of recurrent cardiovascular events, if their LDL cholesterol levels are above 70 milligrams per deciliter, and this is based on clinical trial criteria, then these are the patients who will derive the most benefit by the use of ezetimibe, and I showed you the data related to that from Improve It trial, as you would remember from the earlier slides. And if their LDL cholesterol levels remain above 70 or non-HDL cholesterol levels remain above 100 milligrams per deciliter after starting ezetimibe, then a sequential addition of a PCSK9 inhibitor is warranted. So again, statins first, then ezetimibe, then a PCSK9 inhibitor. Now, some would argue that why do I have to go through ezetimibe first? Why don't I go to PCSK9 inhibitor directly? As you will notice this white box, you can go through to PCSK9 inhibitors directly, but I'll show you some data that it may be much more intuitive to first start out with ezetimibe and then go to a PCSK9 inhibitor. And that's why the guidelines are strongly recommending that we start ezetimibe first and then go to a PCSK9 inhibitor. But you have the option that if you wanted to, you could go directly to a PCSK9 inhibitor after high intensity or maximally tolerated statin therapy. Now, the reason that we are recommending ezetimibe therapy is that if you look at multiple studies that were done in multiple healthcare systems, then almost 60 to 80% of your patients will drop their LDL cholesterol levels below, much below 70 milligrams per deciliter if you titrated high intensity statin therapy and used ezetimibe. Ezetimibe on average will give you 18 to 20% LDL cholesterol reduction on top of statin therapy. In Improve It trial, this was about 24% reduction in LDL cholesterol, but generally about 18 to 20% LDL cholesterol reduction can be expected from ezetimibe therapy, although individual response is different. But we would not know whether this patient is a good responder or not till we use this therapy. And ezetimibe has been out there for a very long time. It's not an injectable medication. It's generic. We have much more safety data compared to PCSK9 inhibitors, which are monoclonals, require an injection, and are expensive, right? So those are the reasons that stepwise addition of ezetimibe followed by PCSK9 inhibitor use is recommended by the 2018 ACC/AHA guidelines. Now, you may ask that when I have a universe of patients who are secondary ASCVD patients, what proportion of those might be very high risk if I use these criteria from the guidelines? And the answer is anywhere from 45 to 55%. So about half of your patients in secondary prevention are going to be very high risk ASCVD patients. These are data from the VA healthcare system, about 45, 43, 44% meeting very high risk criteria. This is from a very large pharmacy data set, and what you'll notice here is that about 55% of the patients all across US would meet the criteria for secondary ASCVD prevention. And that's not the only thing. If you follow these patients exactly as you expected, if you get very high risk ASCVD patients, event rates in those patients are almost 3 times higher compared to those who are not very high risk. And again, that makes sense, right? These are patients who have much more risk factors, and they are the ones who will derive the most benefit by the use of non-statin lipid lowering therapies. I can show you data from PCSK9 inhibitor trials as well. These are post hoc analyses done after the guidelines were published to see what is the benefit of PCSK9 inhibitor, in this case alirocumab, in patients with ACS if they have very high risk features based on the 2018 guidelines versus not having those features. So you will notice right off the bat that the event rates are much higher in those who are very high risk, and you will see that here compared to those who are not very high risk. But that's not the only thing. If you look at the event rates, almost 3 times higher, that seems to be a recurring number, 3 times higher event rates. And when you look at the benefit from the use of a PCSK9 inhibitor, again, almost 3 times higher risk reduction in terms of major adverse cardiovascular events. And when you look at mortality, again, almost 3 times higher, and risk reduction with mortality in those patients who are very high risk. So again, the reason for identifying these very high risk patients is not just that these are very high risk patients in terms of their future risk of major cardiovascular events. These are the patients who also derive the most benefit from non-statin add-on therapies. So now if you look at the guidelines by the European Society of Cardiology and compare them to 2018 ACC/AHA guidelines, there are differences. Again, there are a lot of similarities as well, but there are some differences as well. The similarity here is that even ESC and EAS, European Society of Cardiology, European Atherosclerosis Society cholesterol guidelines, recommend stepwise addition of ezetimibe first, followed by a PCSK9 inhibitor. On the other hand, they recommend LDL cholesterol goal of less than 55 milligrams per deciliter as opposed to 70. Now, I don't think anybody would argue that lower is better. I think we know that. The only question is that what we call the law of diminishing returns. When you drop your LDL cholesterol levels below 70, you still derive a benefit. But if you look at the Y scale, the overall magnitude of benefit is much smaller. So the US guidelines have taken a more practical approach that you drop these LDL cholesterol levels much lower in patients who are very high risk, because then you will derive much more benefit compared to an average patient who will derive some benefit by dropping LDL cholesterol levels further, but it's not going to be as much as a very high risk patient. The other aspect is practical. These are data from Prove It trial, which was done in early 2000s, where everybody either received moderate intensity statin therapy with pravastatin, or they received atorvastatin 80 milligrams, high intensity statin therapy. So if you only look at patients who received atorvastatin 80 milligrams as high intensity statin therapy in Prove It trial, in a clinical trial, in a randomized clinical trial, and if you look at the proportion of patients on high intensity statin therapy whose LDL cholesterol levels are above 70, you're looking at 55% of the patients in a randomized clinical trial, right? In routine clinical practice, this may be much higher. On the other hand, if you drop that line at 50-55, almost 3/4 of your patients will have LDL cholesterol levels that will require the use of ezetimibe or PCSK9 inhibitor. So that is a lot of patients. The other aspect of this is that if you look at some of the recent registries, this is a registry from Europe where patients are extremely well treated. Almost 87% of these patients were on high intensity statin therapy. In US right now, in the best healthcare systems, about 80-85% of patients in secondary prevention are on statin therapy, and 50% or so are on high intensity statin therapy. This is more of an ACS registry, so you see higher numbers. But with 87% high intensity statin use, right, only 13% have LDL cholesterol levels less than 55 at baseline. So you will have to basically intensify therapy in almost 87% of your patients. If you get this high intensity statin use to 100%, which is not possible because a lot of these patients will not tolerate high intensity statin therapy, you get further 8% increase in those who meet the LDL cholesterol target of 55 milligrams per deciliter. If you add ezetimibe to almost 3/4 of the patient, you get about 28% patients more who drop their LDL cholesterol levels below 55. So almost about half of those, but still in half of those patients, you are going to need a PCSK9 inhibitor to drop their LDL cholesterol levels below 55 milligrams per deciliter. And despite that, you will still have patients who will not get to below 55 milligrams per deciliter. So that's one aspect when you're looking at it from a healthcare systems perspective, that if you drop your line at 70 and restrict it to very high risk ASCVD patients, versus if you drop everybody in secondary prevention, whether they're high risk or not, to below 55, what are the implications? The other thing that I wanted to talk about a little bit is that it's not only the statin intensity. The other aspect is adherence. These are data from very large registries. This is data from a national registry in the Department of Veterans Affairs, where again, cost is not even an issue. And again, statins are generic. If you look at adherence in terms of just the refill data, whether the patient filled the prescription or not 80% of the times, almost 40 to 45% of the patients in secondary prevention are not adherent to their statin therapy. So forget about just the intensity of statin therapy and the use of non-statin therapies. We are also facing challenges in terms of adherence to statin therapy. So my request to you will be, the next time you're seeing a patient in secondary prevention, don't just look at the intensity of statin therapy. Try to assess if the patient is actually taking the medication that we prescribed or not. This is secondary prevention, and I can tell you in primary prevention, this is even worse. And why is it important? This is a very well done study from Europe looking at patients as a measure of the intensity of statin therapy that they are receiving and the adherence that they have, right? So if patient is receiving high intensity and they're highly adherent, they have the lowest risk. But look what happens in terms of losing that benefit. Even if you're taking high intensity statin, but you're not adherent, you only derive a 10% relative risk reduction versus 40% relative risk reduction if you were on high intensity statin therapy and adherent, right? And the same holds true for LDL cholesterol reduction as well. So again, it's not just a matter of intensity of statin therapy. Adherence also matters. So when we're seeing our patients, we should not only talk about the intensity, we should also talk about whether the patients are taking those therapies or not. I mean, just like the saying goes, right? Medications only work when patients take those medications. They don't work by just prescribing the medications. Patients have to take those medications for those medications to have an impact. Again, this is something that, I recently wrote in a medical journal. We have a lot of therapeutic inertia, right? But at the same time, patients may have statin-associated side effects, and then we, of course, have to deal with internet, media, and environmental influence that the patients have. And a lot of those are the key drivers as to why we are still struggling with almost 20% of the patients in secondary prevention not receiving a statin, and about 50% of them not on high-intensity statin therapy in good healthcare systems that are working very effectively. So we have a lot of room in terms of improving even the statin therapy use in patients in secondary prevention. So I talked about the guidelines. I showed you that flow diagram that is very easy to follow, not very high risk, very high risk. We talked about how we deal with both of those phenotypes of patients. But since the guidelines were published, there are 2 medications that have been FDA approved. And I thought it would be good to at least let you know where those medications are, what is their use, how do we use them. So at least in your clinical practice, you're caught up on things that have come out since the guidelines were published. So out of two of those medications, the first one that was approved by FDA is bempedoic acid. Now, bempedoic acid, as you will notice, is that it works on the same pathway as statin therapy. It's in the same HMG-CoA reductase pathway, but it's much higher up. It inhibits an enzyme called ATP citrate lyase. But the interesting thing is that this medication is a prodrug. It is activated in the liver by this enzyme called ACSVL1, which is only found in the liver. It is not found in the muscle. So this drug is a prodrug and can only be activated in the liver. So again, the claim to fame is that it does not give you as many side effects as statin therapy does. So this drug now is actually approved by FDA. As you can imagine, this is the same pathway as statin therapy. Statin therapy inhibits HMG-CoA reductase. So if your patient is already on statin therapy, then the LDL cholesterol lowering that you receive from this group of medication is very low. It's about 15% or so. On the other hand, if the patient is not on a statin therapy, you get a little bit higher LDL cholesterol reduction, more like 20-25%. So that's one medication. And again, it shows anywhere from 15 to 25% LDL cholesterol reduction. As I mentioned, there is higher LDL cholesterol reduction in those who are not on statin therapy. There is a combination of bempedoic acid and ezetimibe available, which lowers LDL cholesterol about 35%. I mentioned to you earlier that it's not active in muscle, it's a prodrug, and that enzyme that it needs to be activated is present in the liver, but not in the muscle. So perhaps a lower risk of statin-associated side effects, and it overall has a good safety profile. The two things that you need to look out for is uric acid increase. So if you have patients with gout or baseline increase in uric acid, keep an eye on those patients. And there's a very small incidence of tendon rupture, which we are not able to very well explain as to the mechanism, but it's a very small incidence. If you have patients on steroids, prior history of tendon rupture, fluoroquinolone use, those are the patients you should keep an eye out for and make sure that you either don't use this medication. If you do, then you're keeping a very close eye on those patients. Now, one thing I would add is that the outcomes trial for this particular medication had started a few years back called Clear Outcomes, and an announcement was made that that trial has met its primary endpoint in terms of reduction in cardiovascular events, but we do not know any details of that. Those are perhaps going to be presented at the upcoming ACC meeting in March of 2023. So we'll find out more details as to what was the reduction in cardiovascular events. The second medication that is available, as you all know, PCSK9 inhibitors, you need to give a shot every 2 weeks or every 4 weeks. Now we have inclisiran, which is again an inhibitor of PCSK9, but it's a very interesting mechanism of using what we call small interfering double-stranded RNA. So it's basically 2 strands of RNA. It's a very interesting mechanism whereby it has these GalNAc receptors, GalNAc moieties that bind to specific receptors on the liver. So it targets the medication to liver, so we don't have a lot of off-target side effects. Once it's inside the cytoplasm, it has 2 strands. One is what we call the guide strand, and one is the passenger strand. The 2 strands separate. One of the strands, which is the guide strand, binds to ribosome, and once it binds to ribosome induced sequencing complex, it basically binds to the messenger RNA for PCSK9, and once that happens, that messenger RNA for PCSK9 is degraded, and it does the same effect that you would have otherwise from PCSK9 inhibitors. By degrading PCSK9 messenger RNA, you have more recycling of LDL receptors, and they bring in a lot more LDL particles from the circulation, so your LDL cholesterol levels in the circulation go down. And what we know from multiple efficacy studies is that it lowers LDL cholesterol by about 50% or so. The interesting aspect of this drug is just because it is so much directed towards liver and has such long half-life, that you give dose on day 0, you give 1 dose at 90 days, and then you dose it every 6 months. So now, after the first 90-day dose, you only have to bring the patient back every 6 months to give a dose of inclisiran. Now, we know that it lowers LDL cholesterol, and the mechanism is very similar to PCSK9 inhibitors, but those are monoclonal antibodies that bind the PCSK9 protein. This works through inhibiting the messenger RNA in the cytoplasm. Whether it improves cardiovascular outcomes remains to be seen, and that is a trial that is ongoing right now, and we will find out in the next couple of years whether inclisiran also lowers cardiovascular events on top of lowering LDL cholesterol. So the take-home messages from today's webinar for secondary ASCVD prevention: again, high-intensity statin therapy plus heart-healthy lifestyle remains the foundation in secondary prevention. That's important, whether it's primary or secondary. But the 2018 AHA-ACC Multi-Society Cholesterol Guidelines identify a very high-risk ASCVD group among secondary prevention patients. These very high-risk ASCVD patients are the ones who have the highest absolute event rates, and therefore these are the patients who have the highest absolute risk reduction with the use of non-statin lipid-lowering therapies. Again, statin use and emphasis on statin adherence, both of those things remain the first step before stepwise addition of ezetimibe or PCSK9 inhibitors in very high-risk ASCVD patients. And as I mentioned, we have several non-statin medications that are now under study for use in patients in secondary ASCVD prevention. Two of them are already approved, bempedoic acid and inclisiran. I also talked about that, so you have some idea as to how to use those medications in your patients. With that, I thank you for your time, and we'll take some questions.
Thank you, Dr. Virani, for an excellent presentation. At this time, I would like to introduce my colleague, Rebecca Alicki, out of our National Center. She is the Quality Program Consultant for American Heart Association, who will lead the Q&A portion of this webinar.
Thank you so much, Natasha. So yes, I'd like to open up our Q&A portion with some really thoughtful questions provided by our participants. As a reminder, the chat box or the question box and email ascvdquestions@heart.org will be monitored throughout this portion of our webinar as well. So please feel free to make use of that if any further questions arise. So to begin, we will start with our first question. We have a question: what would be your LDL-C goal in patients with subclinical ASCVD or arterial calcifications? And would you still call them primary prevention?
That's a great question, and a question that is very controversial. What I would tell you is that patients with subclinical atherosclerosis, now those would be patients who have coronary calcium scores that are high or have carotid IMT that's thick. We can debate whether those are primary or secondary prevention patients, but what I'll tell you is that most of the trials that have been done in patients for non-statin therapies have all been done in patients who are classic secondary prevention patients. So I would suggest that if you have a lot of burden of subclinical atherosclerosis, currently the evidence would tell us that those are the patients where we should maximize our statin therapy. So again, using moderate to high intensity, especially if there's a lot of burden of subclinical atherosclerosis, we go with high intensity statin therapy and make sure that patients are responding to LDL cholesterol reduction. We need about 50% or more LDL cholesterol reduction when we're giving high intensity statin therapy. So making sure that we are not just using a high intensity statin therapy in those patients, but they're actually dropping their LDL cholesterol levels to 50% or below with the use of high intensity statin therapy. I did not mention here, but measurement of LDL cholesterol 4 to 12 weeks after initiation of a lipid lowering agent or changing in the dose of a lipid lowering medication also remains a class 1 recommendation. So it's not like fire and forget approach that we put statin therapy and we don't measure lipids. So my submission in this case will be that yes, you can use a lot of non-statins as well if you have subclinical atherosclerosis, but the evidence would tell us that we need to focus on statin and its intensity first before we move towards any other options. And of course, lifestyle remains foundational, even in patients who have subclinical atherosclerosis.
Thank you very much. Our next question coming in is, I understand starting with statin to ezetimibe to PCSK9s, but many patients have intolerance to high intensity statins. In this case, would a low statin to ezetimibe to PCSK9 still be the pathway, or are you likely to add PCSK9 inhibitors to the regimen sooner due to the inability to use high intensity statins from the beginning?
That's a very good question. So again, if you notice on that box in the very high risk ASCVD category, we said high intensity statin or maximally tolerated statin therapy. So whatever is the maximum the patient can tolerate, that's a very nice question. And what we know from clinical trials is that 2/3 of the patients who otherwise are considered to be statin intolerant are able to tolerate some form of statin therapy, right? So what I would do in this case is use the maximal amount of lipid lowering in terms of statins that you can use ezetimibe, and then if you have to use PCSK9 inhibitors, then go towards PCSK9 inhibitors in these patients because you will derive the most benefit. So I would not stop statin therapy, and that's what's not the question either. I would continue with the maximum dose that they can tolerate. And in some cases, that may be 0, but a lot of patients are able to, as I said, about 2/3 of the patients are able to tolerate some form of statin therapy, whether that's low intensity statin therapy and sometimes low dose of a long acting statin, which is rosuvastatin or atorvastatin. If you use 5 milligrams or 2.5 milligrams of rosuvastatin even 3 times a week, 4 times a week, some patients are able to tolerate that. Now, no randomized control evidence to say that it improves outcomes, but we have some observation data supporting that any kind of statin therapy to be used is better than no statin on board. But if the patient is not able to tolerate, then you can very quickly go to ezetimibe and PCSK9 inhibitors. And now, of course, in a month or so, you're going to hear the results from bempedoic acid as well, which is another option you have. And then inclisiran is more of an option that is a 6-monthly option, but we don't currently have the outcomes data available.
Wonderful, thank you. Our next question, how can inpatient providers play a role in intensification while patients are hospitalized and through discharge?
Yes, that's a wonderful question. And again, these are great questions you all are asking. Making sure that patients are discharged on high intensity, but they understand why they are taking it. At the time of discharge, almost everybody with ACS is discharged on high intensity statin therapy. But interestingly, when you follow them a year out, a lot of those patients have either stopped their statin or their intensity has gone down appreciably. And that's why we end up with this 40 to 50% of the patients in secondary prevention are high intensity statin therapy. So what I would suggest is that it takes time, but it can be done by the whole CV care team, right? The clinician who's taking care of this patient, if there are nurses, pharmacists, everybody can be part of this and explain to the patient that why are they on high intensity statin therapy and why is it important to be on high intensity statin therapy, doing that patient education. So we tell the patient that you need to stay on this particular intensity, and not just that, you need to be taking it. As I showed you a few years out, almost 40-50% of the patients are not even refilling their prescription. Forget about whether they've filled the prescription but not actually taken the medication. So working on this intensity piece that the patient understands why they're on high intensity, and doing some of this teaching about adherence as well, because it's a teachable moment when patients are in the hospital. They just don't have the regular life to take care of. They have some time to think about what's going on in their life. So emphasizing some of those adherence related pieces would be very important. If the patient's LDL cholesterol levels are very high, then of course moving towards non-statin therapy during the hospitalization is another piece that you can work on to work towards it. But thank you for asking that question, because I believe it's very important.
Very good. I think we have time for one more question. We just had one come in. The ultimate goal is to have LDL below 70s. What if the patient is a 30-year-old with no comorbidities and LDL and TC elevated? Do we initiate statin if ASCVD risk is below 7.5?
Again, remember what we are talking about is secondary prevention. I have not talked any about primary prevention. That's again a separate part of the guideline. And then the question you're asking is related to primary prevention. If somebody's LDL cholesterol level is above 190 in primary prevention, then again, unless it is driven by secondary cause, which are not common, significant hypothyroidism, nephrotic range proteinuria, chronic liver disease, then one would go ahead and start statin therapy with very high LDL cholesterol levels. Otherwise, the recommendation is to do a 10-year risk calculation. But that's, of course, a different talk. But I wanted to just give you a very short answer to this question on primary prevention.
Great. And then we could have one more in that case. Is fasting lipid panel required prior to initiating statin therapy in the case of STEMI and NSTEMI admission patients?
So 2 points I'd like to make here. One is that for risk assessment, a non-fasting panel is perfectly fine as per the guidelines. When you start somebody on statin therapy or any other non-statin therapy, the recommendation is after that you get a fasting lipid profile. The other thing about hospital admission is, remember, low density lipoprotein is a negative acute phase reactant. So if you measure it a few hours after having an MI, and sometimes after very big MIs, actually LDL cholesterol levels are artificially lower. You may have an LDL done a week or two before their MI, and it may be much higher than what you're seeing in the hospital. So it's not a good reflection. So again, start the therapy, but then repeat LDL cholesterol on an outpatient basis, and don't be fooled by low LDL cholesterol levels when patients are coming to the hospital, because if it's not drawn right away, then in those LDL cholesterol levels might be low just because it's a negative acute phase reactant. If you had a very large MI, in those cases, it may be artificially low and you may not be catching the right number. So always good to start high intensity statin therapy with acute MI in the hospital, but then arrange for follow-up and repeat lipid panel in 6 to 8 weeks so patients and the clinicians can see where their LDL cholesterols are on high intensity statin therapy. And if there is a need to further intensify either adherence piece, intensity piece, or start a non-statin LDL cholesterol lowering medication.
Thank you very much to Dr. Virani, and thank you to everyone for attending today's webinar. If you have any other questions, please email ascvdquestions@heart.org. Once you leave today's webinar, you will receive a survey on the presentation and would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. Learn more about ASCVD at heart.org/ASCVD.